Matthew Holt, another TCB Quick Bite. This is Colby Takeda. He is the CEO and founder of Pear Suite, which has nothing to do with fruit or hotel rooms or whatever. So, Colby, you are actually in the business of improving health equity. You actually won an award for it yesterday at the July Health Foundation. Congrats on that one. But what does Pear Suite do?
Absolutely. We love empowering community health workers and other community-based providers. We recognize that many of these organizations, these nonprofits, community-based organizations, we're doing important work around the social determinants of health, housing, food, transportation, all these important things that we know impact health outcomes, but they're tracking things on paper and spreadsheets, and we're able to partner with health plans and providers. And so we built software to help them collect important SDOH data, to act on it, to solve those challenges with health education, navigation, resource linking, and actually get paid for their work. So you can actually bill for their work now with health plans. So 30 states now offer community health worker reimbursement. We help them activate and utilize those funding streams to make them more sustainable and help the healthcare system incorporate these community-based providers.
Okay, so who are community health workers are a nebulous term? What kinds of organizations and what kind of people are we talking about?
Yeah, these are frontline public health workers. We saw during the pandemic, these are the individuals who are knocking on doors, helping to increase vaccination rates, helping to provide education around resources in the community around housing or how to find transportation to your doctor, help you to find good healthy food, helping people enroll in SNAP benefits. These are not necessarily trained as clinicians. They use their lived experience, they use their background, their understanding of local resources to impact health outcomes for specifically those who are underserved and marginalized.
So you've got people who are probably, not clinically trained, but are smart people and doing good in the community. Who have they typically been working for today?
Yeah, a lot of nonprofits do this work. You think about, you have a health fair, you have these organizations that will go and set up a booth and help share resources. We have community health workers based in churches and laundromats and barbershops and helping to connect with members where they're at. Public housing has a lot of community health workers. You also see some community health workers in facilities like healthcare facilities or hospitals, helping with discharge planning or helping to support the social worker, or maybe they're supporting other organizations like community centers. It's really, really helpful.
And so now you show up. How does their life change in both what they're doing, their relationship to that organization? Who are they working for now? What's the difference now?
Yeah, lots of times these organizations are utilizing grants, right? Short-term funding streams to fund a program or create some new service for their organization's members. Now they can actually tap into this funding stream around reimbursement for community health workers. 30 states have Medicaid reimbursement for community health workers, where if you provide health education, if you do a screening with the member, if you provide advocacy or resource linking, you can actually get paid for this. So we're actually enabling health plans to expand capacity with community health workers by enrolling and contracting with community-based providers, these nonprofits.
So this
our
is
software also
the health plans that are doing this. This is what, Medicare Advantage, S&Ps, Medicaid. Give me a flavor of who this is.
Sure. It started off with Medicaid. A lot of Medicaid plans recognize the importance of social determinants of health with the Medicaid population, but we're also seeing DSNP, even commercial health plans. We have some contracts with commercial plans, and of course Medicare and Medicare Advantage. Last year, Medicare actually CMS approved reimbursement for community health workers with the Medicare population. So all these new policy changes are driving it.
Medicare fee-for-service, traditional Medicare does that.
Correct. Yep.
Oh, that's interesting. Great. So now you show up. You have to go to I assume you start at that end. You start with the payers and say, okay, I can figure out how to get these people on board. What's your sales process? Why would they care?
Yeah. I mean, think about it. Health plans aren't used to contracting with community-based providers, right? These community-based organizations don't know what an NPI is, don't know how to do claims or billing, don't understand credentialing or HIPAA compliance. And so we're really that liaison, that link between these community-based organizations who aren't familiar with the healthcare system and these community health plans that want to work with these CBOs. And so our software allows them to contract and provide that services for these health plan members. We can facilitate screenings and do billing and claims, all the things that they don't want to do. They want to focus on impact and outreach and engagement.
So what is I get that. They haven't had to do it. Why would they do it? What's the outcome? If I give you, I pay for your software, for your technology, and then you put a bunch of people on the system, or there are people recruited to be on the system as community health workers. So that sounds like I'm spending money, and health plans usually don't like doing that just for no good reason. So what happens? What's the reason?
Yeah, unfortunately, health plans have relied on postcards and mailers to engage their members or random phone calls. We know that doesn't work, especially with the underserved, hard-to-reach populations. Relationships matter. Relationships between a community health worker and an individual in the community, it really matters and helps with engagement around preventative services, right? Think about addressing health inequities and challenges around food access, housing. Those are really great things to address before you can help them with their screenings, help them get their annual wellness visit or their flu vaccination. If we can help to address the social needs first with relationships between community health workers and these members, we can help with other things like those flu vaccines, getting them to a doctor, helping them with preventative care, and that makes a difference.
Okay, have you quantified the difference? If I put in community health workers, as a health plan, do I save X somewhere else?
Absolutely. You think about, postcard really doesn't engage these members, hard to reach populations, right? Think about, we've been able to achieve 78% engagement with members through community health workers. And this is things around getting their vaccinations, helping them with screenings, helping them get their annual wellness, just finding a doctor. Those are important first steps to getting them the care they need to reduce things like hospitalizations or unnecessary care.
Have you done a study about that latter part? How much money are they saving in hospitalizations?
Yeah,
data?
So that, as well as all of the benefits of social needs, right? Think about getting someone on CalFresh or SNAP benefits, right? That has a cost savings and benefit for the member around how much they can spend on healthy, fresh produce. Helping them eat healthier food, that has a cost savings. Getting someone a vaccine or a flu shot can help them reduce the illness. All right, all these benefits of getting a community health worker in the mix can really reduce cost savings and increase things like HEDIA and Star. So health plans really care about these things. They want
stars for sure, absolutely.
Absolutely. So it's a great pathway for helping them with their business outcomes while using a really ready, capable workforce.
Do you have to go in with a presentation saying, I'm going to reduce this by X? I'm going to reduce hospitalization by 22%, and I'm going to increase your stars grading by 0.5%. I mean, is that required in the sale, or is the kind of the concept of doing this good enough? How much data does the health plan? How much outcome guarantee do you have to provide before that happens?
Surprisingly, I think there's a lot of good research out there on the benefits of community health workers. A lot of these health plans aren't sure how to work with them, right? How to find them, where to recruit them, how to contract with them. There's so many challenges around that
so
process.
They're sold on the idea, you just have to tell them, that's interesting.
Exactly.
A lot of people struggle with, getting whatever that thing is, getting to a health plan or health provider, explaining how it's going to have outcomes. It's a little struggle. So you're saying that's not such a big deal, they're kind of sold on that. That's interesting. All right.
Yeah.
Tell me a little bit about Pear Suite. When did it start? How much money did you raise? How big are you? Give me the flavor.
Yeah, we started officially in 2021. Went full time with the company in 2022. Have been onboarding organizations since early 2023, and now have over 100 customers in 25 states. In the past 12 months, we've been able to onboard 18 health plans, which is pretty impressive.
Wow.
Across multiple states, and work with multiple business lines, whether it's Medicaid, Medicare, Advantage. We have a DSNP contract and a commercial contract as well. We've been able to expand beyond just software for these organizations. We've actually built a network of CHWs and providers that actually support for these health plans. So think about it, we have over 100 health plans, organizations that we are working with to contract with these health plans. Those have over 1,000 community health workers. So we have a network of 1,000 community health workers across all of our customers that can now work with the health plans to address things like HEDIA and Stars, to address quality gaps, to close those social determinants of health challenges to help with members. So we've been able to kind of build up this provider group, per se, the largest provider group of community health workers to address their social challenges and then support them with things like billing and claims, compliance, adherence, helping them with quality assurance, and helping them with their credentialing process.
So how big are you guys?
So we have about 40 employees now.
How much you raised?
We raised about $3.5 million.
So just a little bit at the moment.
Yep.
Then last question, because you told me this last night over a beer in the post Digital Health Hub Award party, is if I'm a community health worker, what difference has this made to my life?
Yeah, these community health workers are amazing. They're truly special. They use their lived experience, their passion for the community. A lot of these work for free. They don't actually do this for a job. They do it on the side. And for them, this is allowing them to make a career out of this. Use their lived experience to earn money and wages to support their family.
How much were they making if they were making something, and how much they're making now?
Yeah, some of them are working as 1099 employees, making $15 to $20 an hour. Now they can make so much more and get those resources and support they need because their employer can now tap into the sustainable revenue source. And so for them, it's really special. We love the idea that we can employ and support those individuals who can take their lived experience and go on and impact their neighbors and friends and community members, and that's really special. If we want to help Medicaid members, we have to employ them and support them with jobs, and so this is really helping to solve that problem.
Fantastic. We're talking with Colby Takeda, the CEO of Pear Suite. Colby, thanks for your time.
Thanks a lot, Matt.